I've been asked to talk about late effects, which is not something I'd generally put myself forward to talk about. I'm perhaps more focused on causing late effects than helping with them. But I think we've heard a lot in this room that, that those of you who have undergone treatment, that this is a really big focus. These are the issues you're living with every day, and really demands attention from the entire community, myself very much included. A big focus of what I'm doing is making sure that more of patients diagnosed with sarcoma survive and come to these events. But absolutely, in the process of achieving that, we're causing problems which many of you are living alongside. I'm going to start with some good news. Some of this talk again is going to be around when things don't go as well. But more people are surviving cancer. This is one of two graphs that I've allowed myself to put into this, so it's not too much data. But this is CRUK data across all cancers, which show trends over time. So on the bottom there, you've got the year of diagnosis, and on the y-axis there, the percentage of people who are surviving their cancer. And this purple line, this isn't showing up, isn't it? But the bottom line there is the percentage living to 10 years after diagnosis, in many cases equivalent to cure. And so we're seeing basically half of patients now diagnosed with cancer are surviving, which compared to the 1970s was down below 25%. So cure rate has doubled. Which does mean more people are living alongside the after effects of cancer treatment. And this is a word cloud that I put together, pulling through from a paper of interviews with patients who have undergone cancer treatment. And I'll leave you there to look at that. But I'm sure there's words that many in the room would pull down about an experience of living after cancer. And so late effects are the health problems that can endure for months and years and for the rest of one's life sometimes, which are caused by the treatment of cancer itself, as collateral damage really in the effort of ridding someone of the dangerous disease. So what causes late effects? Why is it that we can't just get rid of the cancer without causing these effects? So if you think of your body is your house, and cancer is a fire that has been alit and is threatening to burn down your house, and the treatment is the effort to extinguish that fire. If the fire is put out, there will be damage in the house, which will endure, and you can redecorate, but that damage may still be there. The smell of the fire might endure, or at the very least, you may never look at that house the same again because of the experience of seeing the damage done. And in terms of how we try and address that, I think this is a fire brigade from Bury, I think, in the 1920s. So basically, what did they have to put out fire there? They had a water cannon that would indiscriminately slosh water around, and moustaches, for the most part. Whereas now I think this is a computer-generated 21st century firefighter who's got high-powered precision water cannons, carbon dioxide foams, axes to smash through walls and get to the right fire, get people out. So a more impactful, in some ways more precise fashion, but in the same time, whilst maybe able to direct their effort to put out the fire, is perhaps going to cause even more damage in the process. To talk about late effects in sarcoma, first of all, to acknowledge what sarcoma is, as we've heard multiple times today. This is not one entity. It's a disease that can appear really at any site in the body, and so the effects it leaves is going to be somewhat informed by where in the body it is. And as we've heard now, Sam was saying, I think we're up to over 200 different sarcoma subtypes as well. This is just a diagram demonstrating that this is a very varied disease. What's not captured here is the fact that this can affect anyone effectively from birth to old age as well. And again, the impact treatment might have against someone may be quite different if treated in childhood, early adulthood, later in adulthood as well. We've heard about how surgery is a critical role for the treatment of really most, if not all, sarcomas. Sometimes amputation is what's necessary to get rid of the tumour surgically. Thankfully, less so nowadays, but still necessary. This is a picture of a chap called Terry Fox, who those who know the history of kind of sarcoma and sarcoma advocacy will know very well. Terry was an athlete who lived in Canada, an athlete and a basketball player who was treated for osteosarcoma in the 1970s, requiring an above-knee amputation. As he recovered from that, his focus became very much about trying to raise awareness and raise money. And the initial event was running across the entirety of Canada on his prosthetic leg there, again demonstrating the potential that people can achieve even after amputation. Also recognizing that this is the upper echelons of what people can achieve, and in a lot of cases people struggle to get anywhere near that. This is a picture representing phantom limb symptoms, which those in the room who've required to undergo amputation are very likely to have experienced to some degree. For those less familiar, this is a phenomenon wherein even when the limb has been amputated, is gone, the brain, where pain and sensation is ultimately experienced, remembers the limb being there and can continue to experience pain and strange sensations, which the brain detects is coming from the limb that isn't there, in a manner which is very difficult to treat through in the way that you would do, say, from a sprained ankle from a leg that is still there. And there are a number of approaches to managing those through giving pain relief medication, which can still be effective, through physical therapy, the use of mirror therapy and kind of neurological modulation, which tries to correct for the brain's kind of being short-circuited by the absence of the limb. As I say, thankfully, with progress in modern surgical technologies, amputation is resorted to less and less, and limb surgeries that leave the limb intact are performed more and more. The figure on the left is just reflecting the different ways that a femur can be reconstructed, with the picture on the right showing the soft tissue reconstruction after an extensive surgery for a soft tissue mass, and there's some fancy flaps and reconstruction there which I'm not remotely qualified to tell you about. However, despite these advances in progress, late effects are still seen with those who retain the limb. Stiffness, impaired mobility, altered sensation, persisting swelling, which would be very difficult to get rid of, is frequently encountered. For people whose sarcomas affect within the abdomen, within the digestive tract, a range of issues related to the surgery, be it malabsorption, problems with abnormality in the stomach emptying itself, problems with scarring in the abdomen, which can present with kind of violent bowel obstruction presentations, impairing upon renal function, potential of diabetes. For those whose sarcoma arose around the head and neck areas, again, the surgery can impact upon speech, swallowing, eyesight sometimes, as well as leaving people with noticeable physical differences. And for women who develop uterine sarcomas, men who require surgery around the genital area, impact upon fertility and sexual hormone function, resulting in early menopause, which can be the cause of very difficult to manage symptoms of the here and now and have implications later in life. To go on about radiotherapy, which is a treatment often used in the curative treatment of sarcoma. These figures show an evolution, if you will, of radiotherapy techniques, starting with Marie Curie use of radium, in very kind of primitive version of radiotherapy, jumping forward several decades to a linear accelerator, which is the workhorse of modern radiotherapy. This is a gamma knife device on the top right there, which is basically a linear accelerator on an arm which can articulate around the body and deliver radiotherapy in a more precise fashion. And then the outside of the proton beam therapy center down at the Christie, which, to show a diagram of that, requires schematics of an entire building, but is a further technology, which allows the increasingly precise delivery of high doses of radiotherapy. This is a picture of a planning scan. This is what my radiation oncologist colleagues do as they withdraw into their dark offices to sit and do colouring in as they design where the radiotherapy should be delivered onto the body. This is a axial, so through the body section of someone's pelvis, with the coloured area there being an outline of a large soft tissue sarcoma. This is really just to reflect, however, that it's not just the obvious area where the tumour might be, that where the radiotherapy is delivered, that intentionally the oncologist will draw a margin of normal tissue just to allow for uncertainty as to where the tumour may truly end at a more microscopic level, and then introducing the potential for slight inaccuracies as to how a patient might be set up between day to day, and also how the radiation beam is scattered across the normal tissue as well, which again can lead to a range of late effects, again largely determined by where in the body is treated. So again, if it's a limb that's been treated, stiffness, impaired mobility, swelling, altered sensation, just as we saw with surgery, can all occur, with the potential for causing weakness to bone, as well as chronic skin changes. If head and neck tumours are treated with radiotherapy, visual impairment, dryness of mouth, which is an easy to underestimate source of long-term problems, and hearing impairment are all possible. If it's within the abdomen it's been treated, there's a risk of damaging various organs such as the kidney, as well as causing chronic vascular changes, which can be the cause of difficult to control bleeding. And again, if the genitals are involved in that, cause potential impact against fertility and long-term hormonal issues. With radiotherapy as well, there is a risk of the treatment causing a different cancer years down the line. So sarcoma can sometimes be caused by radiation, and also for women in particular whose radiotherapy involves the chest, there's a significantly increased risk of breast cancer related to radiotherapy. As we go on to the sorts of problems that someone like me might cause with chemotherapy, again, more dependent upon the drug than the size of the body. These are chemicals circulated in the body system. But if we look here at drugs commonly used in the treatment of sarcoma, cisplatin, some extent vencalcroids, and drugs like docetaxel can cause problems with the nervous system, so numbness and weakness in the peripheral nerves, problems with hearing, Raynaud's phenomenon, which is caused by spasm of blood vessels, which can cause a phenomenon where the hand goes very white and painful and then red. Quite common in people in the absence of chemotherapy, but certainly can be quite difficult after cisplatin. Some drugs can cause chronic scarring in the lungs. Others can impact upon heart function, be the cause of increased risk of cardiovascular disease later in life, as well as causing issues such as high blood pressure and diabetes. Many of these drugs are impactful against kidney function, which can endure in the long term and cause problems later in life, as well as certain drugs being the potential cause of irreversible impact against fertility and sexual health, sexual hormone function. In many cases, people will be experienced high doses of steroids throughout the treatment, and that causes risk of skeletal complications also. I mentioned in passing a risk of treatment causing other cancers. That's true of radiotherapy, it's true of certain chemotherapy drugs as well. This is the second graph of two in my talk, just highlighting that from children, this is data from I think 18,000 children treated for various cancers, that if you look at the graph here in blue of the expected rate of cancer as these children age, you're seeing a significant increase. Risk factors from that, in some of these children there will have been an underlying predisposition as to why they got the cancer in the first place, which then may predispose to future cancers, but also those who receive radiotherapy, certain chemotherapy drugs, the impact of radiation delivered through scans as well are all factors that predispose to this. Important in this as well is when you drill down into this data, you're seeing an excess of cancers that you wouldn't expect to be related to any of these factors. So an increased risk of lung cancer, an increased risk of bowel cancer. What underlies, at least in part, that excess is the legacy of treatment for cancer in the childhood can be a predisposition to potentially avoidable risk factors. So that can be things like smoking, reduced levels of activity, excess levels of alcohol, poor diet as well, so it's not just all about a direct impact of treatment, it's the way that cancer has lasting effects that echo through the years in many different ways. I think we've heard about the fatiguing effects of cancer treatment on several times today. This is just a slide to highlight the sorts of factors that might influence upon this. That can include quite tangible factors such as residual pain, impact upon sleep, inactivity, potential underlying biological factors that relate to the legacy of treatment. So there's some evidence to suggest that chemotherapy, radiotherapy can be the cause of chronic inflammation, alterations to the immune system, which may contribute to fatigue, as well as the ways in which the mental health impacts, the trauma of diagnosis, of treatment, of recovery can manifest in lasting ways in terms of depression, anxiety, post-traumatic stress type reactions, which again manifest often in fatigue, blunted cognition, poor concentration, things of that matter. And also beyond that, the psychosocial impact of sarcoma treatment. We've heard again from patients and carers through the team through the day today of the many different ways that a cancer diagnosis, a sarcoma diagnosis, can manifest in the long term in the way that it impacts upon one's emotional well-being, but also impacts upon one's role through work, relationships, the impact upon financial struggles. The way which a cancer diagnosis echoes on is very complex and very individual. I don't, however, want this to be too negative at all, because one would have to be very unfortunate to get half of these ill effects I've highlighted, and is to miss the positive impact that these treatments have in terms of seeing people through dangerous conditions and through to their lives, the other side, lives which unavoidably will not be the track that they were exactly on to begin with, but for better and for worse as well. And there's lots of sources of help to support people with that, and I think we've heard throughout the day today where they might lie. Your regular care team, your cancer care team, can be a source of that, and have listed there the sorts of people who might be involved with that. To my shame, I've missed out the orthopedic team, as I look as my colleague Karen Shepherd, but all sorts of support is available from your care team, and I'd always encourage patients who are struggling to let their care team know. Sometimes the input of other medical specialties can be required, particularly if there is evidence of specific organ system dysfunction. And then in the longer term, we'd always encourage patients to undergo some form of annual checkup to look for potential emergent effects of organ impact, largely because there may well be ways of minimizing the risk of that through things like ensuring blood pressure is well controlled, that any emergent diabetes is recognized and treated, and things of that sort. It's especially important for survivors of cancer to engage with the screening that would apply for general population, breast screening being an example for that, and keeping up with vaccination schedules is important as well to protect against potential lasting vulnerability to infection. Alongside what the care teams might be able to offer is the importance of maintaining a focus on personal well-being, supported by peer support, and we've heard the potential avenues from that with the input from the various charities that we've heard from today being a crucial role as well. I've just put up there what some of these charities are. Sarcoma UK and Bone Cancer Research Trust, perhaps being the largest sarcoma-focused charities in the country. Increasingly, disease subtype-specific groups are organising and providing very specific support, both in terms of input from specialists and peer support, which is fantastic and provides more places for people to turn, as well as the charities focused on supporting younger people alongside cancer, and Maggie's and Macmillan, which I'm sure most in the room will be familiar with. So that's the end of my talk. Thank you very much for listening.